Welcome to this mini lecture on anaphylaxis. My name is Christopher Mistiades. The clinical presentation of anaphylaxis is not always easy to diagnose in the pre-hospital setting, and the pathophysiology involved can be a deep dive into some complex biochemistry. Recently, a number of concerns have been raised with respect to the recognition of distributive shock in the setting of anaphylaxis, and so this lecture will aim to bridge some of the gap between our understanding and management of the patient suffering from an anaphylactic reaction with attention to the management of the shock state. Let's quickly look at the topics we want to discuss. In order to understand the pathogenesis and pathophysiology of the underlying insult, it is necessary to look a bit more closely at the physiology of the normal immune response. Following that, we will look at pathophysiology, clinical features, physical exam, and relevant investigation. We will review pharmacology and transport decision making, as well as the leadership role you may be required to take on at the scene. First of all, however, I would like to acknowledge that I live and learn on the traditional, ancestral, and unceded territory of the Stolo people, specifically the Semath and the Mathexwi First Nation. The Stolo people have lived in what we know as the Fraser Valley for over 10,000 years. The immune system physiology. What is it? Well, it's a sophisticated surveillance system. It constantly interrogates the environment around itself and recognizes danger, infection, and abnormal cell death. It also responds to eliminate any threats that it comes across. A toxin or foreign substance which induces an immune response is often referred to as an antigen or antibody generator. These can be bacteria, viruses, fungi, venom, or environmental allergens. They're often referred to as exogenous if they are foreign to the host, endogenous, produced by intracellular bacteria or viruses replicating in the host cell itself, or they can be an autoantigen produced by the host, examples of which are often responsible for autoimmune disorders such as lupus and scleroderma. A normal response often is initiated or preceded by the innate immune system. This is non-specific and is the first line of defense. It's a quick response, and even if there is no previous exposure to a pathogen or antigen. Antigens or pathogens present on their surface molecules that define self from non-self, and these, which are also known as pathogen-associated immunostimulants, are what the cells of the innate immune system recognize. In response to this, they will release chemical mediators, which can cause inflammation. They will engage in phagocytosis. They can also activate complement, which is a set of 20 proteins that normally enhances the action of antibodies and other cells in destroying the pathogen, and they can trigger the adaptive immunity. The adaptive immunity is a specific immunity. It also obtains an immunological memory as a result of its exposure. This often beginning as early as fetal development. It requires sensitization to an antigen before activating a response. Antigen-presenting cells, known as APCs, are often monocytes, macrophages, and dendritic cells, will present the components of the antigen that have been digested or destroyed to the T lymphocytes, indicated here in the black rectangle. These T lymphocytes, or T4 helper cells, through a series of chemical reactions through chemical mediators, can activate another set of T lymphocytes. In doing so, the Th1 cells expressing CD4 surface receptors will activate macrophages, these cells that surround and kill microorganisms also remove dead cells and stimulate further immune response. The T lymphocytes, through the expression of CD8 surface molecules, will also activate cytotoxic T cells. These are responsible for lysing the target-specific antigen-bearing cells. CD4 cells also activate B lymphocytes to produce antibodies and to develop into memory cells. Antibodies are typically switched from IgM to IgE on the surface of the B cells, and these IgE immunoglobulins or antibodies are what are responsible for the major allergic and anaphylactic reactions that we will talk about subsequently. IgE antibodies will attach to the mast cells or the basophils either with an antigen or by themselves. In doing so, they will create the release of chemical mediators, specifically histamine, cytokines, prostanoids, heparin, growth factor, proteases, leukotrienes, and chemokines. Mast cells also have the capability to crosstalk between the innate and the adaptive immune system via a lot of the chemical mediators that it releases. This results in clonal expansion, which ends with antigen-specific memory T and memory B cells being produced. If all goes to plan, these reactions are self-limiting and will produce a more rapid cellular and humoral response on next contact with the antigen. A self-limiting response means that the host has immune tolerance. This is often the result of T regulatory cells, which inhibit the pro-inflammatory proliferation via negative feedback loops. So what could possibly go wrong with something so complex? Well, immune deficiency can occur. This often exists when T4 helper cells are attacked and destroyed by viruses, commonly occurring in HIV. There may be an autoimmunity in which the immune response is misdirected against the host's own cells, or transplanted cells, known as alloimmunity, or an exaggerated response can result in a hypersensitivity reaction. Hypersensitivity is an altered immunological response to an allergen. It results in damage or disease to the host. It's often a type 1 or IgE mediated and is responsible for a lot of the allergic and anaphylactic reactions that occur. Activated mast cells that are preformed activated mast cells release preformed substances such as histamine and tryptase, as well as de novo mediators, often leukotrienes and prostaglandins. These result in fluid extravasation and maldistribution, resulting in hemoconcentration, hypovolemia, a reduced venous return to the heart, and subsequent low filling pressure, causing reduced stroke volume and reduced cardiac output. Even if the immune system is checked at this early stage and is just localized, communication has already been sent to other components of the immune system that can continue to respond more slowly. And these are often responsible for the late phase reactions with potential reoccurrence of symptoms, as well as the tissue destruction and mucosal epithelial tissue damage that occurs. Some of the clinical features of anaphylaxis are seen here, and it's interesting to note that in all three definitions, or accepted definitions, blood pressure changes appear. This is significant in the fact that in addition to distributive shock, which causes vasodilation or caused by vasodilation and vascular permeability, there may be a mixed shock state. Hypovolemic shock can exist as a result of reduced blood volume, and cardiogenic shock, reduced coronary flow, arrhythmias, brady and tachycardias. And an obstructive shock state can exist somewhat temporarily with increased pulmonary vascular resistance. In evaluating the components of the cardiac output, it's easy to see how anaphylaxis can elicit a spectrum of insults to the cardiovascular system. These need to be considered when developing treatment plans. Remember, do a thorough primary assessment and consider early interventions. The faster the onset, the more serious the situation. When evaluating airway and breathing, look for wheezing, stridor, laryngeal edema, angioedema, and hoarseness. In circulation, consider hypotension and tachy and bradycardias. Disability should suggest that you evaluate the level of consciousness and any evidence of any syncope. Look for urticaria, rash, flushing, evidence of bites, stings, swelling, and any vomiting. Other relevant investigations should include what symptoms are associated with the physical findings. Is dyspnea, sensation of a lump in the throat, itching or nausea, diarrhea, abdominal pain or cramping present? From a past medical history, any previous episodes of known allergic or anaphylactic reactions may increase the concern that you have for the patient. Are there any treatments needed, such as over-the-counter medications, prescription medications, or has there been any admissions to hospital, emergency rooms, or even ICUs in the past? A medical history of other medications, including antihypertensives and beta blockers, as well as calcium channel blockers, should be determined, as these may play a role in a more profound and protracted anaphylactic response. Importantly, the history of this current event. Is this a known or an unknown exposure? Also, the time and the rate of onset. Again, remember that the faster the onset, the more serious the situation. Determine the route of possible exposure, and has there been any treatments administered, such as antihistamines, an EpiPen, or any metered dose inhalers. Further consideration should be given to the differentials, which can mimic an anaphylactic response. Vasovagal being the most common, but acute myocardial infarctions, arrhythmias, status asthmaticus, as well as seizures, can also mimic severe allergic reaction or anaphylaxis, as well as epiglottitis and hereditary angioedema, along with foreign body airway obstructions. Carcinoid syndromes are caused by tumors releasing or causing the release of chemicals that can cause flushing. And mastocytosis is a buildup of mast cells under the skin, resulting in itching, but can also cause GI symptoms such as diarrhea. When reviewing the pharmacological interventions, you need to consider what we need to do to optimize the patient. Oxygen will optimize oxygen delivery to the tissues. Epinephrine, through alpha-1 receptors, will reduce mucosal edema, but will also cause vasoconstriction to help reverse hypotension and perfuse the heart, lungs, and the brain. Through its beta-1 receptors, it will increase heart rate and contractility to support cardiac output. And through beta-2, it will reverse bronchoconstriction, as well as stabilizing the mast cells. It will also help reduce pulmonary vascular hypertension a component that was causative in possible obstructive shock. Initially, epinephrine can be given IM, but if there is cardiovascular collapse, it should be given IV. And if refractory hypertension exists, consider an infusion. Crystalloids should be given to replace lost circulating volume to support venous return and improve preload, and usually 1 to 2 litres concurrently with epinephrine infusion, 10 to 20 millimeters per kilogram in a pediatric patient. Remember that the airway takes priority. However, being able to optimize the patient prior to securing the airway may not be possible. Therefore, a RSI involving ketamine and rocuronium should be considered. This with ketamine being a non-competitive NMDA receptor antagonist utilizes endogenous catecholamines, reducing the risk of hypotension. And neuromuscular blockade facilitates first-look intubation success, as well as reducing laryngospasm. In the presence of beta blockers, refractory hypertension may require the use of glucagon. This is an inotrope and a chronotrope that's not mediated by beta receptors. In addition, refractory hypertension should also prompt you to consider vasopressin and norepinephrine. In combination, the synergistic effects of V1 receptors and alpha antigeneric receptors may have a benefit. Transport decision making is an important role here. These can be profoundly difficult crises to manage, and especially on scene, they require quick diagnosis, a commitment to treat, and aggressive therapy before and during transport. The role of the paramedic has changed over the years. The load and go lights and sirens part of the job has diminished what used to be a large portion of the job. Transporting the patient to the hospital as quickly as possible has been turned on its head. Good clinical leadership is required at the scene, as paramedicine is bringing the ER and ICU to the patient's side. Questions that you need to evaluate are: is the patient going to die before you get to the hospital? What interventions will make a difference right now? Where can those interventions be done? And where should the patient be transported to? Often with the anaphylactic patient, interventions need to occur right away. These include epinephrine, oxygen, fluids, and securing the airway. Early transport is perhaps necessary, but you need to consider what the benefits of that are. Certainly in the setting of a STEMI, early transport to a PCI, or in the setting of trauma, early transport to a trauma receiving facility where surgical intervention can take place is necessary. But in this case, transporting a patient with an unsecured airway in a state of hypotension can be detrimental. Remember also that during transport, keep the patient as supine as possible to prevent the effects of the distributive shock and vasodilatory and maldistribution of fluids. As the leader, often those with the highest clinical skills will take the leadership role. This requires good communication skills and patient advocacy. Remember, as the leader, take charge, assess the situation, minimize any barriers to care, and communicate effectively, as well as delegating tasks, and examine the patient thoroughly. Be aware of situational awareness and recognize your limitations. You may not be the best person to intubate. Delegating that task to somebody who is more likely to have first pass, first success is often what needs to be done. I'll leave these references up here so that you can review them, and investigate further from some of the resources that are used. Thank you.